Hey everybody, welcome back. David here with Med School Boot Camp. So now in this chapter, we're going to talk about a very common pathology called nephrolithiasis, more commonly referred to as kidney stones. So the breakdown is that we're going to start with an overview, general symptoms and presentations, then talk about the various types of nephrolithiasis, or at least the most common ones. And by doing all of this, you should have a pretty good idea of what the common things they want you to know for test day and how to get your questions right. So if you all are ready, then off we go. So in this first video, we're going to do kind of a general overview of nephrolithiasis or kidney stones, and then we'll talk about each one individually. So just thinking about the classic presentation, it's really important to recognize when a patient presents with unilateral flank tenderness. This is important, right? Because it would be unusual for a patient to have bilateral kidney stones simultaneously, and so typically it's located on one side or the other. The flank region is essentially referring to kind of low back pain that can extend somewhere between the ribs and the pelvis, and so isolated pain in this area can potentially be indicative of a kidney stone. It's also important to know that we get colicky radiating pain most commonly to the groin or the inner thigh. And this is important to recognize as well in a question stem. If they talk about unilateral pain that's potentially radiating to the groin, this is potentially consistent with a kidney stone. Some of these symptoms are going to depend on where the stone is relative to the kidney, how far along down the ureter it is. Is it proximal near the kidney or is it distal near the bladder? It's also going to be altered by the size of the stone. So it might be reasonable to think that a smaller stone would cause less pain than a larger stone. And it's also important to note that these patients will classically present with hematuria, which is the presence of red blood cells in our urine. And again, this should make sense, right? If we have a stone in the ureter or in the urinary system, this can kind of scrape against or damage the surrounding structures, leading to the presence of red blood cells in that area. It's important to note that we need to use more information when we're answering these questions, right? Just because a patient has flank pain or some groin pain or potentially even lower abdominal quadrant pain does not specifically mean that they have kidney stones, right? There's some other things like appendicitis, testicular torsion that can cause a similar presentation or pain in these regions, but it's a good idea to start thinking about your differential early on. What things fit for this patient? And then using additional information that the question would provide you to figure out what the correct answer is. So next I want to talk about some general risk factors for patients with kidney stones. One of the main ones is a decreased hydration status. And this can be either from a decreased intake or drinking less fluids or an increased excretion, right? If a patient's taking diuretics, potentially too much of those diuretics, this can cause them to have fluid offloading and overall a volume depleted state. So how does this help with the formation of kidney stones? Well, let's say we have two containers with equal amounts of volume. Each of them has 5 particles of solute. However, what if we were to take one of these containers and decrease the amount of volume or the amount of water in that container? What would happen? Well, if we decrease the volume or the hydration status, this is going to increase the concentration of the amount of substance per liter. That is to say, if we have 5 solutes over here and 5 solutes over here, but on this side we have 1 liter unless we have 5 solutes per liter. However, over here we have 5 solutes per 0.75 liters. This is going to be a more concentrated substance. And a more concentrated substance is going to predispose you to greater risk of kidney stone formation because the increased concentration makes it more likely for these stones to precipitate or to form. Another general risk factor is going to include an increased amount of what we call stone-forming substances. So hypercalcemia, hyperuricemia, or hyperoxaluria. We'll talk about in future videos. These are all things that form stones. Calcium stones are very common. They can bind to a lot of different things. One of the more common stones is the calcium oxalate stone. So it should make sense to you then that an increased amount of these substances, right, is again going to increase the concentration, increase the risk for precipitation, and ultimately forming stones. One of the really important things that they want you to know is what the diagnostic steps are for working up these patients. And the best initial imaging is going to be the non-contrast CT scan. So if you draw your attention to our image over here, you can appreciate this bright white stone being shown on the image. This is why it's so important that this is a non-contrast CT scan. Because if you remember, what happens when we use contrast? That's right, it causes structures to light up. It causes structures to look white. And because the stone looks white on imaging, if we were to use contrast in these patients, we wouldn't be able to see the stone at all because the entire system would look bright white. So a non-contrast CT is particularly important here. It's a very high yield thing to know. It's equally high yield to know that there is a class of patients in which we would not want to use CT scans because we risk radiation exposure to the fetus, and that is in pregnancy. So the best test there, the best initial imaging would be an abdominal ultrasound, with the reason being that you want to limit radiation exposure to the fetus. There are some other alternative imaging options that are probably not going to be the correct answer in a test question, but I want to mention them here just so you're familiar. One of these is called a KUB. These are not typically preferred because they can actually miss really small stones in the urinary system, and they also are not very good at detecting hydronephrosis. However, CT scan, or a non-contrast CT scan specifically, is very good at detecting both of these things, and that's why it's the preferred imaging study. You could also use an MRI, but we know that MRIs are very expensive and time-consuming, and you can also do something called an IV pyelogram, which is rarely used because we have access to CTs. Additionally, another thing you would want to do to work up these patients is to get a urinalysis. And what do you think this urinalysis would show? That's right, you might see some hematuria, potentially gross or microscopic hematuria on the urinalysis, indicating damage to the urinary tract, potentially being nephrolithiasis. Next, we want to think about what are some of our general management options. So each specific pathology is going to kind of have its specific treatment options, but overall there's some general things that we would recommend for anyone, no matter what type of kidney stone that they have. And the first thing is going to be hydration. And we talked about previously, right up here, that the more concentrated your urine or the lower your volume status leads to an easier pathway for stones to actually form. So increasing the hydration status, keeping lots of fluid and volume, decreases the risk of saturation of the stone-forming solutes to ultimately create a stone. Next, we want to look at things like dietary modifications. And these include things like limiting sodium, oxalate, and excessive vitamin C intake. So why? Why would these help? Well, for sodium, if we think about our pathways in the kidney, we know that high levels of sodium is going to decrease the RAS system. Because if we have high levels of sodium, that means we're probably going to have high levels of extracellular volume, which is going to downregulate RAS. This makes sense, right? Because what is RAS typically doing? It's typically sensing a low sodium level, a low circulating volume, and it's activating. So if the opposite is true, if we have high sodium, a high circulating volume, we're going to get a decrease in the system. If we get a decrease in the system, it's going to decrease the amount of sodium reabsorption in the proximal convoluted tubule. Again, we're doing the opposite of what we would expect to see if we were to activate RAS system, in which we would bring back more sodium. But if we downregulate RAS, we're bringing back less sodium. And this is important because bringing back less sodium causes less reabsorption of calcium. Remember from our series on the nephron transporters, sodium reabsorption and calcium reabsorption are tied indirectly in the nephron. And so bringing back less of one, sodium in this case, brings back less of another. And what does that do? Well, if we have less calcium reabsorption into the body, we have more calcium left in the urine. This is going to increase our risk for stone formation. And so that's why limiting sodium is actually helpful for limiting the risk of stones in some patients. Limiting oxalate is also important because we know that calcium oxalate stones are one of the most common. And so anything you can do to decrease a substance that would then create a stone is going to be useful. And it's also helpful to avoid excessive vitamin C. And the reason for that is oxalate is actually generated from an excessive use of vitamin C. So too much vitamin C creates more oxalate, which increases the risk for calcium oxalate stones. In our calcium video, we'll talk more specifically about the pathway in which patients can actually develop high oxalate levels in their body if they have a condition such as Crohn's disease or have had gastric bypass historically, and how this can actually increase the level as well. So more to come in the calcium video. General management is also going to include things like pain management. So just dealing with the symptoms using medications like NSAIDs could be helpful. You can also consider using a couple different antispasmodics such as tamsulosin or nifedipine. And remember, tamsulosin is an alpha blocker, which can actually relieve some of the spasms in the ureter. Remember, stimulating the alpha-1 receptor causes constriction, and so if we're blocking that stimulation, we can actually get some relaxation, which can improve the patient's pain or symptoms. It's a similar principle for nifedipine, which is a calcium channel blocker, which can also cause some vasodilation or relaxation of some of our urinary structures. And finally, the last general thing to know here is that larger stones might require more invasive measures such as a ureteroscopy or shockwave lithotripsy. It's a general principle that smaller stones can typically be treated with hydration or more conservative measures, potentially some of the medications, and the bigger the stone gets, the harder it is to remove from the patient, potentially requiring more interventional modalities. We'll talk more specifically about each treatment option for the different stones in upcoming videos, but these are kind of just general overviews of general guidelines for treating kidney stones in most patients.